Good morning, everyone, or good afternoon. It's 12 o'clock Eastern Standard Time. Good morning to everybody in Central Standard Time at 11 a.m. Thank you for joining us today. We're very pleased to have Kathryn with us. And Kathryn is going to be, this is the billing part 3, and she is going to share with us some answers to the questions you've had over the last 2 episodes, part 1 and part 2. And as well as some questions that we have received. And she's also going to share with us a little bit about the last presentation she participated in at the ASET conference. So if you didn't get to make that, but you were at ASET, you'll still get that. And if you weren't able to make it at ASET at all, then hopefully this will help you out too. So thank you very much, Kathryn, and I'm going to turn it over to you.
Thank you so much, Sarah, and thank you to Rhythmlink for allowing me to do this. This has just been a great exercise, a lot of fun, and I hope most of you or all of you have really learned a lot. And hopefully that learning process has been a fun exercise as well. It's always helpful to have a lot of feedback from you, so please don't hesitate to ask questions. That's how a lot of us learn. But it also helps me to be sure that I'm fulfilling your expectations. So let's look at the art of coding and billing, and this is part 3. And we're going to repeat and review some of what were significant and frequently asked questions in our first 2 sessions. But I also have a little different twist on it. Maybe it helps to improve the understanding of the process at that point. So our learning objectives today, we're just going to learn about the 2025 coding CPT codes, but even more specifically, we're going to look at different variables that impact the choice of a CPT code. And we're going to focus on neurodiagnostic procedures. And if we have time, we'll go through a checklist. And part of this is where you have to work so diligently with your revenue integrity team to have a good outcome with the coding and building. I've created a little checklist that will help you to ask questions of your revenue team. And that's not absolute, but it is certainly a way to start the dialogue. So one of the questions that we were faced with many times, but I think this is important from your perspective, and it's called the NCCI edits. Now, this is a really different approach to coding. The NCCI National Correct Coding indicators, and those edits state that when a modifier is permitted on a billing code. Now, a modifier is an additional 2 digits that helps to explain some facet of that code. For instance, there's a modifier when we're doing a charge for the professional fee. And there's a modifier when we do a charge that's just the technical fee. And so this question was focused on 95720 and 95816. If those are done on the same date of service, is there a modifier? Well, the NCCI edits is where we find that. We aren't going to pair it if it's not sanctioned under the NCCI edits. What that means is you don't quite sure when you use the modifier, go to the edits and match up the 2 codes that you are wanting to add a modifier to, and it will tell you if it's permitted or not. So the answer to this question is the 95720 is billed for the professional interpretation. It is not a diagnostic code. And the NCCI edits will not accept a modifier since this dedicated code differentiates it as professional. So the question in which modifier was considered here was the modifier TC 26 or PC. 26 is what Medicare wants for a professional service. And you might also see some of the other third-party payers want PC, professional component, as the modifier. But this is where you look at, generally, you're getting the information. If you edit, if you compare and build two codes on the same date of service for the same procedure. That's the NCCI edits. So that was one where we had to really try to clarify that, and so hopefully this helps. Another question we got both during one of the sessions and after the session is really talking again about the independent testing facility, the IDTF. And so this is a CMS definition, and that's because CMS is the one who actually defined the presence and designated a different testing entity, and it's independent of a testing facility. Facility here for CMS always means a hospital tax ID number. So a hospital campus. And so an IDTF is non-facility based location that's doing diagnostic testing. So you probably know of a lot of portable diagnostic testing entities. They would likely be an IDTF. So non-facility is outside the hospital setting, outside the hospital campus. And it can be a fixed location or a mobile location. So one note here is if the diagnostic service is provided in the physician's office, coverage and payment policies apply as it is still considered an IDTF. However, the difference is it's owned by the physician generally. So it's a fine line, but just so that you know, a take-home message here, it's not hospital or facility based, not related with a hospital tax ID number. Hence, the billing is considered under the IDTF category, and it can be portable, it can be stationary, it can be in multiple locations. The real careful part here is the IDTF cannot share space nor diagnostic equipment with a Medicare enrolled provider or an organization. That is fraudulent. So this is one of the things where we are careful to look at when we see applications come from an IDTF. Next, let's look at a little deeper dive into office versus hospital billing. Now, office billing is done on CPT code. Office billing is done basically for procedures done on an outpatient basis, diagnostic testing, or the physician is an E&M, an office practice, and it's all confined to that office. And as I said, it's outpatient. Now, let's look at three scenarios because you can be working in an office and still have a tether to the hospital. And so I'm going to give you three scenarios in which knowing more than just outpatient CPT coding will be important. The first is Okay, it's a diagnostic procedure that's done in the office. The physician owns the office, owns the equipment, and does the interpretation. Generally, you will do what's called a global billing. That means it includes the technical and the professional all in one code, and that's provided. The owner of the equipment is the physician or the provider, and the patient is seen by the provider. So generally what we look for there is it the provider's patient that you're testing? And is it in the confines of the office that the provider owns? Does the provider own the equipment? So that's a classic outpatient testing, outpatient billing. Now, I'm going to put a caveat in here, and one consideration here is making sure that the Stark Law is considered, and this is the Stark Law is self-referral. So one of the things that has to be defined is this is the physician's own patient. Hence, it gets a little there's other questions to answer if the patient is being referred by another physician into that practice for testing and possibly for consultation. So now let's unravel that. When is it self-referral and when is it not? So if you have a patient being referred by another physician, and that happens a lot in neurology, and they're being worked up, and the physician says, oh, I'd like to run an EEG or do an evoked potential or some diagnostic procedure while you're here, or let's schedule it for you to come back. This is key because even though that patient was referred to that physician from an outside physician, it becomes the physician owner's patient. Why? Because they're doing a consultation or an office visit on them to define medical necessity for the diagnostic procedure. That is not self-referral. That is an appropriate way to have that patient seen and tested. Now, let's take a second scenario here. A physician refers to this practice a patient for diagnostic testing. The question of self-referral, you'd have to ask then and verify. Does that referring physician have a financial relationship with the owner of the diagnostic equipment? Maybe it's a family member, maybe it's a partner, maybe it's a relationship. As long as there's a financial relationship, that would become a self-referral, and that is fraudulent. The Stark Law forbids self-referral. So those are some of the considerations when we're talking about purely the office practice and referral for diagnostic testing. Let's look at a second scenario, and that's the office, the physician in your office, your outpatient office, is asked to interpret diagnostic procedures for the hospital. That would be a contractual billing for professional services. So what does that mean to you for the office doing the billing? You look at the contract, you look at what is permitted under the contract, and you would submit a claim, but your place of service would be hospital as opposed to office. The other important part here, with all contractual billing like this, you have to submit an invoice to the hospital unless there is a fact in the contract that speaks to you do independent billing for your professional services. And so that's where the contract language becomes very important to understand. If it is a contractual relationship for professional services and the contract speaks to that you do the billing for the interpretation, then you would use the CPT code that you would use in the office for interpretation. However, the location or the place of service would be hospital, and it would still be hospital outpatient. Now let's take the third scenario. Coming from the lens of the outpatient office. The owner's physician of the office contracts with an outside entity to provide equipment and professional staff and interpretation of studies. The contractual payment with the hospital has to be defined. Who does the billing? Sometimes the hospitals will do that billing, and you have the contract for a fee for equipment, staffing, and interpretation. So you would bill the hospital for the services rendered. The hospital would drop the claim for the diagnostic procedure, knowing that it was contractually completed by another entity. Or you might bill only professional services under that arrangement, or you might bill just for procedure and interpretation and not staffing. So you see, there's a lot of different ways in which the office as an outpatient entity can engage in different billing relationships. And I hope this helps you to see that there's many facets to billing, many facets to relationships. More and more of these relationships are occurring in contracting with hospitals because of staffing issues. So let's advance to another facet of what are some of the challenges that you face with office billing, and you have a relationship or a contract with a hospital. First of all, if the office billing team needs to know how to bill DRGs and outpatient prospective payment systems. So you've got your inpatient prospective payment, you've got your outpatient prospective payment. DRGs are inpatient, APCs are outpatient. So this adds a little bit more complexity, understanding those billing arrangements. So if you're in the office, you still might have that relationship to have to know what the billing constructs are for inpatient and outpatients that might be seen in the hospital. The other, and this is a really important one, and it might be beyond the scope of what you want to hear today. However, I'm bringing this forward because it's an important consideration, and it might be that we have some revenue integrity folks on as well. But if you're in the office and you're contracting with the hospital, if the contract requires you to do your billing, then you will need to be credentialed with the insurance providers the hospital accepts. So it's no longer just the providers, the insurance third parties that you work with in the office, but it would also have to be in network with the ones that the hospital accepts. So that's conceivably a lot more complex, because what that means then is you have to do applications to more insurance companies, most likely. A third challenge is staffing, and you contract with the hospital. What about stat procedures? What about emergency room admissions later at night? And this is where we want to talk a little bit about cerebell. And I'll come to that later or in the next slide. However, I want you to really see now, remember we're talking about the location being your outpatient office, but look at how it's overlapped with many facets that could be possibilities for coding and billing from an office billing team as it relates to relationships and contracts with other service providers. So these are challenges from an office perspective and your outreach and different facets that can occur. Now, let's talk a little bit about cerebell. There was a question about that, I believe, in our second session, maybe our first session. But I did a deep dive on this because this was kind of, it's not in the coding manuals and for, I think, a good reason yet. Let's drill into this. It, as you all know, it's the 24/7 continuous bedside EEG monitoring. Okay, so I had an opportunity to talk with both techs who use it. I talked with their sales rep, I talked with a clinical rep, and I read a great deal on it. So I have kind of a 360 approach to this now. And I just want to enlighten you on some challenges and in the opportunities. And it uses artificial intelligence. So in this particular situation, it's machine learning. So they're using a deep language model to anticipate what is being recorded and the likelihood that a seizure will occur. Or the continuous EEG for seizures is based on a deep amount of information that's been stored over many, many recordings, and it's fed into using AI. Okay, now I'm not opposed to AI as long as it's got a validated basis. I think this is not new. In the 60s, I was using what you would call today AI. I was using what you all know as evoked potential average signals. That's nothing more than that. Think about you're lapping, you're taking many, many, many waveforms and you're overlapping them and averaging for an outcome. That's what machine learning is doing. So for us in neuro, this is not a new thing. However, it's a new language. The one thing that I kept being, when I was doing my deep dive, the question that came and coming up, who is available to interpret continuous EEG for seizures? Or maybe it's not being interpreted. Okay, that's a question. First of all, I can anticipate that you may say, well, who gets to bill for the interpretation? Well, that depends where it's done and who's doing it. Secondly, who bills for the EEG? That depends where it's done and who's doing it. I'll come to that. Okay. So one of the other statements in my talking to a number of techs was all you're seeing is circumferential lead placements. And so I asked the question, well, what about Rolandic seizures, anterior temporal foci, or parasagittal seizures, or maybe you've got a scar tissue that's creating an irritative focus in the parietal region. how do you add extra leads? Well, this is not the scope of Cerebell. And so I kept trying to get confirmation from a lot of techs who have used it, saying, so how do you ensure that what you're seeing is based on and comparative to, say, an EEG with extra leads? And that was not the intent of Cerebell. Now, Cerebell also is not new, only it's not called it. What I worked with when I was in my early days in at Mayo Clinic was, it was similar. It was looking at thermographic changes in the brain as a reflective of compromised flow, compromised areas of brainwave function. So it's come a long ways. It's amazing, and it's a really valuable tool as long as you have a consistent platform that has been validated. And in my questions to the company, they had an immense amount of data that had been used to validate the information in the large language module, which facilitates then the machine learning. And that's where you then say you're using artificial intelligence. So there were consistent, comparative, validated alerts for suspected status epilepticus. And I think that word suspected is really important. So I'm not saying this is a technology that is a real opportunity. One of the questions that I have from a billing perspective, and now as I was doing my Q&A with with a number of other people, here's where we come back to that earlier question. Who is available to interpret the continuous EEG for seizures or not? Is it who's billing for it? Is it the hospital? Is it the lab? Is it impacted by a transfer from the emergency room to inpatient status? Yes, that is different. That does impact the billing. So let's step back. Now I'm creating more questions than I have answers for because I'm not doing these procedures in the same way that you are doing them. But these are the questions I want you to ask your billing team. I want you to sit with your team and say, let's talk about this. Let's talk how we work out the revenue and the billing and the staffing for this. And those were questions that were asked of me of technologists that I queried who were using Cerebell. You know, they had as many questions for me as I had for them. So the one thing that I want to put in your to-do list, if you're using this type of technology, first of all, where is it being done? Is it intensive care? Hence an inpatient? Is it in the emergency room? That is a different billing status. So is it DRGs? Or is it your outpatient codes, your APCs? Another consideration here, and this is where I used to spend a lot of time, was in the intensive care unit. And if we had long-term monitoring, let me rephrase that. At this time, we had some real-time monitoring of blood pressures. All of those were included in the hospital room charge. There was not a separate billing code for some of the technology that was doing ongoing monitoring for health and safety of the patient. So, is this treated like a vital sign monitor? I don't know. I think that's where you have to have a conversation with your facility. I know that when I had these kinds of questions posed to me, and we were monitoring a piece of equipment in another area than our lab, and it wasn't just us that were responsible for the engagement of that equipment, then nursing became involved. And the big question then is, who's doing it? And what is the level of charge associated with it? If it's in an intensive care unit, chances are, and it's continuous, it's going to be treated like a vital sign monitor, and then there's not a procedure code for it. It's considered in some form and fashion of the hospital room charge. Okay, I'm not saying this is occurring. I hope you all understand that. I need you to be able to ask the questions. How is this being treated? These are some of the variables that you will consider. If it's the EEG tech, the neuro tech, the night tech, and you're doing the setup and the monitoring, then you've got an EEG CPT code for it. Okay, question that came almost from everybody. Can we bill for the electrodes? To this point, there's no code. I could not find anything that would allow this. I even looked at 2026. I just finished scouring all those new codes that are coming in, and I don't see anything that is a peripheral. Now, I will say this. When I used to be over radiology and cardiovascular labs as well, and there were times when we had special equipment that had to be used. Let me rephrase that was used. And it was outside usual and customary. And what we would do then is we would bill a non, just a general code, and it always got denied. But we tried and billed a non-listed code. And on occasion, if the history and physical and the report identified, the interpretation identified, this was outside the usual and customary electrodes that were needed for this patient, then we might get a few dollars back. But it took an appeal, and it took a well-scripted appeal in the interpretation to qualify that it was necessary for the state of the patient and the health of the patient to use additional resources. So what's at play there then? You really do need good dictation. You need to have a strong relationship with the interpreting physician or the attending. You need to be able to see this documented well as medically necessary. And that's the key, medically necessary. So I've presented to you a number of questions, a number of challenging decision points. I don't have the answers, but I do have a lot for you to take back to your billing team and start talking about this for your individual locations. And I'm also, if you have different questions that go with this, please ask them, because I can probably ferret through some of the data that I amassed as a result of being prepared for this discussion. Okay, let's transition to DRG considerations. And this is really an important part, because I know that many of you work in a hospital. And then now you've seen how I correlated that if you're not working in the hospital, what this means from a DRG, having to know DRG if your physician is working in the hospital, or maybe you've got an office tech who works in the hospital. So DRGs, diagnostic related groups, are billed for inpatient. And it's part of what we call the Inpatient Prospective Payment System, or IPPS. The corollary to that, look at the bottom here on the slides, is if it's outpatient done at the facility, it's billed Outpatient Prospective Payment System. Okay, so that's pretty universal and fairly representative of location, the place of service. Now what you need to know is a DRG is one payment for the entire stay. And so there's a major payment, and then different parts of that payment are sent to, say that you do long-term monitoring and the EMU, and you've got 5 days. You would get a % of that one major payment. The levels, there's 3 levels of DRGs, and those are based on severity. And in a minute, I'll come to how that looks. But now we're talking about the type of admission. So you've got your admission, your inpatient. DRGs, one bill for everything, or one payment for everything, and it's severity based, 3 levels. Now, another type of admission, and this really isn't an admission per se, it's an observation. Observation codes are, you're going to keep you for maximum of 48 hours generally, and we're just going to watch you and see how you do. They might be put in a hospital bed, but they're not categorized as an inpatient. You've seen observation units. They might be an extension of the emergency room. That's still considered an outpatient. But it's usually within 48 hours, we're going to see how this, we're going to watch you, we're going to manage you, and then you might be discharged. Now, here's what's key. It's billed as an outpatient, even though they might be admitted into observation. So they're not admitted to the inpatient area where DRGs take over. This seems confusing to outsiders, and I appreciate why, only because I've worked with so much of this on EMU units and status epilepticus being held in the emergency room under observation for 48 hours, that I learned to really understand the nuance. When they are prepared to either, after about 48 hours, they either have to be admitted as an inpatient under DRGs or discharged. Who determines that? The attending, plus you'll have a department in the hospital that reviews all these charts and considers the readiness for their discharge, and often communicates with the attending about the health status and if they're ready to be discharged. Or if not, then they have admitted to the inpatient unit. Now, the take home here, and I'm throwing this in because I have a lot of friends that they have cardiac issues, and they'll be seen in the emergency room, and then they're held overnight, and they'll tell me, well, I was admitted overnight. And I'm thinking, you weren't admitted, you were observed. And they say, yeah, I was upset when I got a bill for another copay. Now, here's the key, is that observation is an outpatient. They're going to get billed for a copay. They get billed for the inpatient copay. If they're in the inpatient, they're going to get billed as an outpatient copay. It's not just the procedure code. Now, that's a little on the side. That's more for your edification, but it also helps you understand some of the nuances with observation care. The next one is outpatient. You all are familiar with outpatient. I'm not going to spend a lot of time. It's billed CPT codes. It's procedure codes. and then outpatient done at a facility. So outpatient office, outpatient facility. Done at a facility, that's billed under the outpatient prospective payment system, and it's APCs. So you've got the corollary to DRGs is APCs, and I have that in a slide. So I just want you to see the types of admission. And this, I get a lot of questions when they talk about the EMU. The patient was admitted, or the patient was in the EMU as an observation. Some of this has to be differentiated. The other is, they'll say, well, the child went in for X, Y, and Z, but they say they were billed as an inpatient. Okay, here's another question. How long were they there? What kinds of procedures? What level of care was needed? And with epilepsy, there's a lot of consideration for that. Okay, I'm going to stop on that drilling down, and I'm going to go into then some facets of DRG considerations. So we want to verify the type of admission. So in an inpatient, you've got your major diagnostic groups. That's what a DRG is. It's a diagnostic related group. It's determined by severity, and that's how the principal diagnosis is defined and used. So you have major versus minor versus other kinds of surgeries. You have major versus minor versus other types of severity. So is this hard? Yeah, it is hard, but it's not impossible. It's an algorithm of severity. So the presence or the absence of a complication and comorbidity and major complications or major comorbidities, all these are facets that go into determining the DRG. Let me say this another reason. The reason for the hospital stay triggers these questions. Is it major versus minor surgery or other type, maybe the Mohs procedure, which you're taking a slice of tissue and just analyzing for a cancer cell? Does it have complications and or comorbidities? If so, are they major? All of those are questions that go into what DRG are you going to use? And that's associating your principal diagnosis. If you want more on this, I've given you here the URL to go into cms.gov so that you can do a lot of reading about it. I will say that it took me a fair amount of rounds on DRGs to understand its implicit, unique differences. Next, let's look at how it's impacted by the location of the services. And this is where you've got facility, hospital, inpatient, outpatient hospital. All of that's going to impact your DRG, or here now you see APCs. So if you're doing a patient in a facility as an outpatient, it's APCs. If they're admitted to an inpatient status, it's a DRG. If they're admitted to observation, it's outpatient. So I hope you see now, it is complex, but there is some rhythmic relationship to it. So what does this impact? One set reimbursement is based on the hospital cost report. That's a major report that every hospital has to submit to CMS. And it's an average value of similar procedures based on similar use of resources. And I'll give you an example here in a minute. So procedures that have a similar cost, similar amount of time, but it might not all be just EEG. You might have EKG and EEG together. You might have another type, you have evokes and maybe a cardiovascular procedure. All of those can be lumped as long as there's similar procedure, similar use of resources. It does not include the professional fee. It's only the technical and facility expenses. So that's how the magic comes forth. And one of the best exercises I did was to work on all of my procedures for all of my different departments on changing from outpatient coding to this APC. And it really teaches you a lot about costs and how to manage costs. Next, let's look at what this is an example for you of what the APC can show you. Now, on the left, you have the traditional, in the hospital, they call it the HCPCS code, but it's really your CPT code. And then you see the different descriptors, and then you see the APC. You can see how there's the stratification as the resource becomes, as the procedure becomes more resource intensive, greater needs, you have different sections. You have an elevated, like level 2 tests, level 3 tests, and more complex level 4 tests. And you can see the difference in the payment rate. So I hope this gives you kind of a pictorial analysis of where we are with the relationship of hospital billing coding, inpatient versus outpatient hospital services versus observation. And then looking more deeply at the APCs or the outpatient procedures that are paid based on resource demand and availability. So let's take an example. So changing the patient to an inpatient status may constitute fraud. Now I bring this out because I also work on that side, analyzing claims. These procedures are paid as APCs rather than DRGs. And that's where if you were to bill federal insurance claims, and even third party now, commercial insurance, if you billed for a procedure as an APC, because you might get paid more, but it was really classified as an inpatient admission, then you're going to find the denial for the APC and you're going to be paid under a DRG instead, and vice versa. For commercial insurances, non-Medicare, the claim will be denied as an inpatient status due to the CPT codes should be used for commercial insurance. Okay, so remember, DRGs are federal insurance. So this is where the auditing becomes important. Now, are we outside of your scope? Well, we can be, but I'm going to challenge you on this. And this was something that came up at the ASET meeting. You know, the importance of, as a tech, in your role is understanding the broad scope of your practice and how you impact the revenue stream, and understanding that maybe something as simple as your documentation, and I say as simple because we are good at documentation, but maybe not all the key points we need for getting the claim paid. And so let me show you where this can be questioned in the EMU monitoring location or a special circumstance for monitoring. And let's take what we do a lot of, and that is medication monitoring and the titration of your anticonvulsants, or you're weaning from one class of anticonvulsants to add another class. I remember I did a lot of that in the EMU. And really at that point, I had to ask my attending, what status was this patient admitted under? Was it less than 48 hours and they were in the EMU as an observation? In which case, then I knew my documentation had to take on a little different specificity. However, this is bringing out to you some of the complexities, but yet you have a team that you can ask. And that's where I say, become a knowledgeable technologist to ask these questions, because that's how you're going to advance your career as well. And then maybe there'll be somebody to take over my role here, because I'm thinking that there's somebody else who can do this as well, and I'll teach you if you want it. But the best practice here is compare the reimbursement with each insurance. Calculate. Now, you've got a revenue integrity team who can help you with this, but look at the reimbursement you're getting with each insurance. Calculate the impact of the revenue and the insurance class versus the APC. And that'll give you a good feel for how to maximize your reimbursement and to monetize the revenue health of your department. Okay, now I might be getting in the weeds, but I really want you to know that if something comes up a couple of weeks from now from your revenue integrity team, and you're going to say, wait a minute, that's what she was talking about, you're going to have a eureka moment and you're going to be absolutely on top. This is where this knowledge becomes so important. I want to remind you from a long-term EEG monitoring perspective, and you've seen this many times. You see it in your CPT manual, but I just want to remind you. Remember, this has the professional services, which are different codes than the technical services. And notice the differentials here. Your technical services, is it unmonitored? Is it intermittent monitoring, or is it continuous monitoring? The word monitoring matters. Is it video and EEG? Only video, only EEG? Look how this all is described. Look on the far left, that first column, and it gives you without video, without. You see where it's important. If it's EEG monitoring, then, and you want to know whether it's intermittent or continuous, then go to the video and the EEG. Go and read the definitions here. That'll help you to see it. Notice the professional services. And if you're in the office and your physician is rounding in the EMU, this becomes real important, is knowing if it's every 24 hours with a report or if it's different characterization. Also, I know you've seen this if you've been in my sessions before, but it's very interesting. I had a lot of questions about this after my presentation at ASET. Where do I get this information? Well, this is an example, and I just have 2020 in this. It hasn't changed. It's still there. But I just pulled this down because it was easy to download, and you can see where your key piece of information is. I think if you want to be a good biller and a good tech that's using billing to advance your career, you need to know this particular website and how it guides you to answer questions. Another particular is, and this is getting back to that, what about video monitoring, EEG recording? When the language says, do I do continuous or do I have intermittent? My first question is, tell me what you're asking. Is it intermittent video, continuous EEG, or is it continuous video, continuous EEG? That matters. And then you follow the directions of the code. Note, recording has to be at least both. The recording has to be at least 80% of the video recording has to be at least 80% of the total study. And people will say, well, what about your breaks and your, say, an interruption to go to a testing, maybe MRI. As long as you've got that 80-20, you've got continuous, unless you break that down. And if it's in monitoring is interrupted, it is billed as intermittent. So we have to look at recording versus monitoring, and those are together. They're not interchangeable. So this was another question that keeps I'm being asked, and it's very easy if to clarify. If you unhook and then rehook within 24 hours, do you bill a separate study or just a continuation of the previous study? What does your code say? You have a hookup paid once every 24 hours. This is within 24 hours. So no, you would not be able to charge a hookup again, and you will bill it as a continuation unless your physician says otherwise. But look at the codes. There's codes for with X number of hours or minutes in the 24-hour clock. So it's actually billed on a 24-hour day. This is inpatient, asks for long-term monitoring, and we charge a setup fee, 12 to 26 hours. They ask for the patient to come down and 2 days later come back. And can there be one more setup charge in the admission? Can there be more than 2 12-hour in one admission? Well, 2 12-hour is 24 hours. Okay, so yes, there can be more one setup. It has to be separated by 24 hours. And in this example, there's 2 days between the two monitoring events. And then it says, I can't tell you without more information as to what the billing code is, because I don't know if it's with or without video documentation. So the other thing that I often see is the difference between 95700 and 95999 is I don't see any credentials of the tech setting up. So it's going to default to the 95999 as a paid claim. if there's no credential, to say that it's a registered tech or a competent EEG tech. So documentation is important. I think we can pass on this. Sara, do we have some questions? I think we've kind of gone through this.
Thank you, Kathryn. I'm not seeing any questions right now. I don't know if anyone has any questions they want to ask. We still have several on the line.
I want to also, the new requirements for long-term EEG monitoring. The requirement is an EEG tech. And here you see the definition. Does that mean that you have to be registered? Excuse me. No, and this is coming from ASET.
And I believe also ACNS and that was involved in this definition too, correct, Kathryn?
Yes, ma'am.
Yeah, ASET, ACNS, and possibly even ASNM, I'm not sure. But I thought there was one other.
Yeah, all three weighed in on this.
Okay.
Now, I want to bring this out because I had quite a conversation at ASET about credentials. And Doug, is it important? Well, yes, it's important because it validates a level of standardization. It validates a level of competence. And it's also a recognition that you are practicing in accordance with regulatory requirements. Now, all three of those agents that Sara commented on all have published standards and requirements. That's why this is here. And if you are not practicing in adherence with those standards, you open up yourself for risk. You open up yourself for challenge. And one of the things that we hope you never have to do, but if you did end up in court, an attorney will right away discount your testimony if you're not able to define yourself from your credentials, and you are unable to show your education, training, licensure, certification. So let's step back a minute and let's talk about this relative to, is it a requirement? No, we're not telling you you have to do it. We're saying it is a good practice to do it because you want to follow the scope of your practice, and that's governed by your professional organizations. And there's laws, there's licensing, there's regulation, there's policy. All of that goes into this. And so you open yourself up for challenge that if you do have your licensure, you have your certification and training, and you can show that, then that puts you in a different sphere of recognition. So
Kathryn, we do have a couple questions. I'm sorry to cut you off there. So one of them is to confirm this does not define that someone needs to be registered to be monitoring.
This does not define registry is required. However, and this is your caveat, I am seeing third-party payers dictating what they will cover as an approved credential. So this is where you want to not only look at what the three organizations qualify as a qualified EEG tech, but you also have to look at third-party payers. I know of several that are saying you need to be a registered tech to do certain procedures.
So another question we have, is this due to people other than EEG techs placing devices such as Cerebell and Zito?
Oh, that's so fascinating. That is it due to, or is it one factor? It's one factor. I can't say it's a one-to-one. It's one factor. Now, I'm going to go a little farther with that. I think new technology is great, but new technology has to be embraced. It has to be validated. One size does not fit all. As well, if you're starting to work with new technology, you want to be very certain you've been signed off on a competency assessment on that technology. Going in cold does not get it. And one of the things that I frequently see when I'm on survey is, because I ask for the competency checks, they're required annually. How many of you have been signed off by a more qualified, more expert technologist on your competency? Does competency verification equal performance improvement? Not necessarily. Performance improvement is how you're doing your tasks. Competency checks is verifying that you're doing your procedures according to the policies and procedures and the standards. So they're usually elements within the same timing, but they're not separate, optional. They're both required. Now, let's go back to a situation where you might be challenged for your decisions that you've made in a study, and it ends up going to court. I would certainly, as an attorney, I would say, show me your competence checks. Have you had them checked? And by whom? Was it somebody more senior than you that is knowledgeable and qualified? Or is it somebody from another division that they just happen to be over your supervising your department? So can a vascular tech who has never done an EEG check you off on competence for an EMU patient? You can answer that question for yourself.
So we have, so in addition to the previous question before that one, we have an accredited lab with many registered CLTM and NACLTM care team members. Do you know if it is within the scope of practice for advanced technologists to be providing preliminary reporting during the night with the final interpretation being completed in the morning?
That's a sticky wicket, and I'm going to answer it in two ways because there's a piece of information there I don't have. That is, when you are saying you're providing information in the middle of the night, are you describing it? Are you giving technical information, or are you saying this patient has seizures? I saw seizure activity. I saw spike and wave, or I saw electrographic seizures. You're making a diagnosis. If you're sharing clinical information, and this is key, and your medical director supports that and covers you in other words, sponsors you, then that's fine. You're doing it under the direction of the medical director. But if this is not sanctioned by hospital policy and the medical director, then I'd be very cautious on doing that. And to answer the question succinctly, no, there is not a sanctioned practice for that. But you see the other questions that you need to answer. Now, I think all of us have called our attending. We've said, you know, we see this and this and such. That's fine, because that attending understands what you're talking about. But if you're calling a nurse on the unit and you're saying this patient is having status, who are you talking to? Are you talking to the charge nurse? You're talking to the patient's nurse that just came on? You see, you've got to make some sense and sensibility out of this. But you wouldn't do that in absence of your medical director covering you, because that medical director then is ultimately liable.
So I want to say, one, thank you for everybody staying on. We do have up to 2 CEUs, so up to 2 hours. So I'm going to go ahead and continue with the questions because we've got quite a few coming in, Kathryn. So are audiologists able to bill for the professional component in regards to IOM services, or does it depend on the insurer?
Well, there is a code for it. Yes, it does depend on the insurance as to if they allow audiology coverage, and that's written in there. It's on the website of who's covered under that CPT code. So you just have to get in there and look. I will give you a guidance on that. In 2026, the CPT codes, you're going to want to look a little deeper into the procedure codes. Make sure you have the more updated procedure codes. Don't look at one from 2-3 years ago, because some of that is changing, and I think it's changing for the better. But that's just my side of it. But you want to verify that you're an approved covered. Yeah.
So now that you brought that up, we do have a question. Are there significant changes to CPT codes coming for 2026, 2027?
Not in EEG. Not in EEG. There's code changes in interoperative monitoring, and it's more under the cervical and low back. I did not pull those out. I reviewed them last night, but I didn't put it in my memory. But they're very easy to identify. And if somebody wants those codes, if they can email you, and I'll give the 26. And of course, 27 isn't out. We don't still have 26. We just know that it's being published. But let me rephrase that. We have 26. I just took my CEs on it, but it won't be in the CPT manuals and won't be available until late October, 1st of November. And it's not posted on the fee schedule yet on CMS, but I do have the approved ones.
Okay, thank you. And then we have ER nurse puts Ceribell on patient and charges for hookup setup in less than 2 hours. Is this acceptable?
Well, the ER nurse is, what's the policy of the hospital? Is this a domain of the ER and it's their equipment, or is it the domain of neurology and it's your equipment? I mean, we placed a lot of monitoring equipment in the emergency room for them to use, and we trained them. And it was their cost center that supported it. It was their staff that supported it. And we were the bailout if they ran into troubleshooting, but it wasn't our equipment. Conversely,
if I understood correctly, the 95700, the hookup disconnect education, that wouldn't be by an ER nurse, correct?
Nope, that's the domain of neurology and EEG.
And the same thing with the less than 2 hour EEG billable code, correct?
That's not there. She's not doing an EEG.
Yeah. Okay.
It's a definition. Yeah.
Okay.
Yeah, and that's why I wanted you to have this deep dive into Cerebell, because it raises so many questions. And that's where I said, does this go into the ER visit? Is that how they recoup it? It's going to be denied. But that's the push and shove of it.
Thank you, Kathryn. And then are ambulatories billed as outpatient is one of our questions.
Well, generally, yes. It could be observation. You know, somebody's being held for status into post-icto, and it goes into their recovery as taking a while. You've all seen that metabolic encephalopathy that could be seen with it, and they're holding them because they're not safe to go home and discharge. So
the ambulatory study they're putting on and sending the patient home.
Then that's outpatient.
Okay.
Yep.
All right.
But see, we used to keep some of those patients in the ER, and it was for convenience of the patient, but it was also for safety.
Understood. If a physician intermittently monitors the study, but the tech does not, is one billed differently?
That's a good question.
And they are different codes, correct? Because you got the physician component and you got the tech component.
Yeah. So if the physician is monitoring intermittently, boy, that's nice. That's fortunate. Who's communicating in the absence of the tech? Now, the question here is, yes, that would be professional interpretation, but the professional is not going to bill the EEG. They're going to bill for the interpretation, because notice what the description of that code is. It's for interpretation. So in the absence of a tech, you have unmonitored according to the CPT code. If you have I'm thinking the CPT code, I mean, how blessed to have the physician in and out on that, but it would be intermittent if it's the physician doing it anyhow. It's not continuous. But see, the continuous is a qualified tech.
Yeah.
So that's kind of a new approach to interpreting the CPT codes. And in the absence of other information, no.
That is a good question. And I know one of the hospitals I was at that we were fortunate enough to have a doctor too, that especially for those overnight studies, she would intermittently be popping in and checking on things and watching things. And so if something went down that the tech, was trying to get it back up, then she was always like, I've also been watching it. So yeah,
Yeah,
it's not, it's very rare.
Yeah. But the difference between what I interpreted the question to be and what you stated is you were
Yeah.
there. You were there. You were the tech there. But I interpreted the question to be in the absence of the tech.
You are correct. She does say, but the tech does not.
No,
So
that's no.
yeah.
That's scary to me. That's unmonitored.
Okay. And then we've got another one here. Where can we go to find out more for setting up our own IDTF? Do I need an NPI number?
Yes, you do need an MPI. And setting up an IDTF is like setting up an office practice. And there's very good information on the requirements on the Office of Inspector General website. OIG, Office of Inspector General website. It's also got some interesting, good stuff on that website. But that's where you can find it. You can also find it through, there's a section of CMS that has information on it, but it's not as detailed. It has more of the regulation side of it. And there's also I'm part of another agency. It's AHIMA, and it's American Health Information. It's it's the organization that your medical records staff go to. I go to them because they have great information on just the process of medicine, and they have some really good information on IDTFs. I haven't looked at their website lately for IDTF, so you might go there and do some search on that. AHIMA, AHIMA, all caps. But that's a good place to go. And you do need an MPI, and you do need to be registered as a medical facility in every state in which you're doing business.
Okay.
And that means that your technologists have to fulfill the technical practice requirements of each state. Some states have requirements for credentials and others don't.
Great. And we still got people on, so I'm going to keep going. Here's another one. Are there any changes in 2026 for CPT codes for ECOG in IOM?
No.
I know right now there's just the 95A, is it 29? I'm trying to remember right offhand, or 95820. I'd have to look it up to be positive.
I don't believe so. If they want to email me, I'll do some research on that, or they email you, it's easier. And
yeah, we've got some people sending us their emails, so we can definitely, because they're all very interested in these CPT codes for 2026.
Yeah, EEG, well, it's not a big, it's not. I breezed through that in about 2 minutes.
Okay. Yeah. And then also, if a patient from the EMU, Kathryn, goes ambulatory after several days of being in the EMU unit, does that change to a different code or stay for hospital?
They go ambulatory, meaning they go home and you're monitored there.
So the way I'm understanding the question is, so if a patient from the EMU goes ambulatory, so I know I've had this before where, we're going to go ahead and discharge the patient. They've been in the EMU for a few days, but we're going to go ahead and put an ambulatory device on them and send them home with the ambulatory device for up to 72 more hours,
It is different because you're discharged from the hospital.
Okay, very
And-
good.
Yeah, and you have, your EMU has full-time monitoring, is that correct?
She does that's not mentioned in the question, so
Okay, so here's how to unravel that. The first is, you're being discharged from inpatient from DRG. You're going to outpatient, which is CPT. You could be going from full monitoring to intermittent. We don't know. But the key here is, when you're leaving the hospital, you become an outpatient, and that's CPT. Whereas EMU, unless your hospital has an exception in how they've arranged this, it would be DRG.
yeah. And you make a good point there, Kathryn, because some places monitor ambulatory EEGs, whether it be intermittent or continuous, but other places do not for their ambulatory. So ambulatory EEG studies. Thank you for that. And then we've got another one here that if you have 26 patients on LTM, wow, that's a lot, and are able to maintain a 1-to-4 ratio for continuous monitoring for 8 of the patients in the ICU. So we got 26, we've got 1 tech for every 4. And so continuous monitoring for 8 patients in the ICU. And then, but they need to drop to intermittent monitoring for the other patients. Are you able to bill continuous for the patients that remain on the 1-to-4? And if so, what do you need documentation wise? So I'm going to stop there because there's still more, but let's go ahead and answer that so far.
Okay, this is 4 or 5 parts. So
I'm jealous. I want this many monitoring
Yeah.
screens and this many techs.
Okay, so you've got 8 patients who fulfill the requirements for continuous monitoring.
Correct.
And you bill those individually. So those 8 patient charges would go in as continuous. See,
Yep.
it doesn't matter how many people you have in the cohort, because you bill everybody individually.
Okay.
What matters is how many staff you have. So you've got 8 patients, 2 staff. Yep, they fit. The other, if you don't have staffing, let's say you have 8 patients to 1, then you have intermittent. You can still bill that intermittent, because you just because you bill 8 of them one way doesn't mean you bill the others the same way. In fact, it's fraud if you do.
Yeah.
So that's a really good question.
You also have to, like, it's for the whole stay too, correct? It's not per day or per shift.
Yeah. Yes, correct. It's for the whole stay.
So if that if one of those patients that you're charging continuous is on for 3 days, it has to be continuous for all 3 of those days.
Yep.
Not just 1 day.
Yep.
Okay. So I'm going to continue with the rest of the questions here. For the same one, we have a PEDS monitoring room in our children's hospital.
Sarah, if I may interrupt, sorry.
Yeah.
The question also with that, the 8 patients, 1-to-4
Oh, documentation wise, what do you need?
documentation. Oh, I love this. Okay, I love documentation because it's so critical. So you want to be documenting intermittently. I personally, when I look at these cases, I want to see hourly documentation. And the reason being is, first of all, it's proof that you're there. Secondly, document that you are monitoring. Don't assume we read your brain. The third is read your brain, read your mind. I guess it's one and the same. Third is document some of the vital signs. Now, and observations. Document observations. Document when you've done your impedance checks, because you should be doing intermittent impedance checks. Document that. Document if you called the doctor about something. Document if you talked to the nurse about something. If the patient says something, put it in quotes. All of these are really important because you never know when there's a jewel, a piece of information that explains the whole story. Yeah.
And you always say document like I would document Sara and my credentials, correct?
Absolutely. Yes. Mm-hmm. Good. I think that helps with the rest of that.
Okay. Yeah, because they have here that we have a peds monitoring room in our children's hospital and an adult monitoring room in another hospital. But we pass patients between the two rooms as needed with staffing and incoming orders. If we maintain a 1-to-4 ratio in one monitoring room for those patients and are not able to maintain that ratio in the other monitoring space, are we still able to bill continuous? And again, I think, so that's the second part of that same question. I think it still, if I'm understanding you, Kathryn, correctly, it all goes down to, making sure you have one tech for 4 patients throughout the continuum of their stay.
Mm-hmm. Yep. And one of the things that I always like seeing when I look at charts, because it prevents me asking questions, is the tech will document, I am currently monitoring 1 to 4 patients, still monitoring 1 to 4 patients, monitoring 1 to 4 patients. In other words, if a patient goes off, I'm monitoring 3 patients, currently monitoring 3 patients. You see what that does is it says, I know what the requirements are, and I'm telling you without you needing to ask.
Yeah. Yeah. I think we got everyone's questions. I'm looking to see, I hope we answered them clearly for you all. I know billing is such a bear. And as Kathryn said, she would love to retire and she definitely deserves it. If anyone out there would like to be trained by Kathryn on how to do this, because we definitely need it in our field. I called on Kathryn when I worked at Mayo and was in IOM. And then also, I also called on you when I became the manager at another facility. And we were trying to, with all the 2020 changes that came about with the LTM. So Kathryn also is able to go to hospitals and help you out. I should have taken advantage of that. Now I'm not in the hospital, but she can come to see you and help out with all that. Correct, Kathryn? If you want to explain a little bit of that.
Well, it's part of helping under the revenue integrity team and the service to work together. And that's really an important part of success. It's also how both parties learn. And what we often have to look at there is, what are the cases? Because for revenue integrity, waveforms are Greek. For EEG, long-term monitoring, billing is Greek. So you come together and you break down and you do go through cases and you say, what if? Oh, look at this. And the real key here is taking the results of the study, the interpretation, comparing it to the history, and having a discussion about this is what we both agree would be the likely code. Now, that sounds like a long enduring process. Once you start framing that, it can be done quickly. And one of the things that I like to be able to help with is get your team together, establish some relationships and some ground rules is what you're going to talk about. And also the other thing is there is no dumb question because that's how you all learn. And the way I started was I had my revenue integrity team dumped about 30 charts on my desk and said, fix these. These were denied. Well, I didn't know anything about it. So I said, you all sit down with me and we'll talk it through. And it was amazing what we accomplished. And that's how I got my start into this, was just by looking at denied claims and with my revenue integrity team. So that's the magic sauce, is bringing the teams together. And you start to break down the barriers and you start to create the common dictionary of terms.
Yeah, thank you, Kathryn. We did have two more that just came in wanting some clarification. So does this mean as long as you maintain continuous for certain patients, continuous monitoring throughout the continuum of their stay, that other patients can be monitored intermittent the same day due to not being able to maintain continuous during the patient's entire stay? So
yeah,
I think we also need to clarify, like, if it's intermittent, it's intermittent throughout. If it's continuous, it's continuous throughout.
Well, yes and no.
Okay.
Yes, it generally is. But let's take a situation where, and this I can see happening, where you have a patient who is very sick and they've been continuous monitored, and then they need care and you're in and out, in and out. It could be intermittent. So what you would do is you'd look at your grid and say how many hours were continuous and how many hours went to intermittent. As long as you can break it down into that range for that code and it fits in there, that works. Now, the challenge you're going to get, and you are correct, as long as it's the same, continuous for the stay, the challenge you're going to get is third-party payers don't like that. And they'll give you a denial and ask for records. If you're good at documenting, you can usually appeal that. But I have to say, the appeal process is just very, it's just so disheartening. It's just one thing after another. I'm not so sure it's worth it. However, if you want to look at the technicality of that, you could break it down, but I don't know that that's good practice. But you all heard me. The technicality is yes, but I don't know that it's good practice.
So another clarifier, if you are continuous monitoring one patient for the first 24 hours, but the next 24 hours you are only able to intermittent monitor, is it okay to bill for continuous for that first 24 and intermittent for the next 24?
Yep.
Or are you required to maintain one type of monitoring for the duration of the admission?
No, that's why you have different codes.
Okay.
Now, here's where you're going to get into questions. Why? Why can't you maintain the same level of monitoring, of continuous monitoring? What is the reason for it? And see, the documentation there is real important. The other piece is you have to have a conversation with your doctor first.
But
And
this
why?
is the same, we're talking about the same patient for 2 days for 48 hours.
Mhm.
Okay.
Yeah. But yeah, the codes are there that you can do it because the codes are broken down in amount of time for a reason. But why are you not able to sustain it? Or is it the clinical condition that changed that you don't need it? In which case, that's a very important documentation piece. Because at me as an auditor, I'm going to look at that and I'm going to say, in the absence of any documentation, what's going on here? Why? Why the change? Is it staffing? Is it patient related? You know, this is the documentation piece that's so important. And I think that this is really where you have such an opportunity to tell your story.
Yeah, I agree. And so I guess in thinking about that, that last question there, and so when it is a continuum, so it's the whole stay. So we have a patient that's staying for 2 whole days, we can break it up.
Well, if your medical director or the attending allows that.
Okay.
You can't do it willy-nilly. That's why I said, why is this happening? If you're
Gotcha.
saying it's staffing and you haven't consulted with the attending, I have a problem with that.
Okay.
And you should have a problem with that. If you're saying it's a change in clinical condition, it's the licensed provider who's dictating that then. And that would be a notation in the chart. So see, that's why I get a little squirrely with that question because I don't know all the details. It's not an absolute. It's all very situational, very patient driven.
So I have a question for you. And I don't know if anyone else on the call here, on the webinar here, would be interested in this. If, I want you to come in and help out, that would be one thing. But when do you come in and do this auditing that we're not requesting?
When?
What causes for you to come pay me a visit if I'm still the manager at the hospital and I haven't requested you to come in and help me out, but you're there to audit me? What would cause that visit?
Question of fraud.
Okay. All right. Very good. So if there's some maybe billing issues that, I'm billing along the lines, if I'm understanding this correctly, or the techs, that I'm working with, we're all billing one way, but that's not the way it should be billed, then that's when we may get a visit from you that we didn't request.
Well, yeah, and I wouldn't say that this is whoa, 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 whoa. I think there's something. Sometimes administration wants an outside review because they don't understand why they might be losing money. They want to look at a way of making better money. They might look at a way of how to streamline service. They might be looking at a contraction or an integration of multiple departments, and they want to maybe look at what some of the regulatory requirements for that. There's a lot of reasons. At the end of the day, if it's totally without provocation or request from the facility, then it's probably a complaint or a question of fraud. I have to say that rarely occurs. For the most part, people want to see how to reframe their practice. Let's just look at where we can see some revenue opportunity.
Yeah, I know that's exactly why, I called you for the IOM piece, was to make sure we were billing correctly and going to get back the revenue that, we should or wanted. And then same thing when I went to the other facility as the manager of the lab, wanted to make sure that, we were doing, No, I called you several times over a 5-year period, 5-year plus period, because wanted to make sure that, we were definitely getting the revenue because as someone in the lab, you want to make sure you're getting all those monies
Yeah.
in order to prove that you need more staffing, you need, all those things, more equipment, whatever it is you need, when you get into leadership roles, how important that revenue piece is.
I will say one thing. I've had 2 occurrences where there was a complaint about the qualifications or the question of qualifications of a tech. And these complaints go sometimes to the Office of Inspector General, sometimes directly to CMS. The other is it could come on a Medicare site visit, which occurs in facilities on a regular basis, or a state site visit. And they might see that there's some questions of qualifications. So that could be a consideration. The other is making sure that if you are practicing as the qualified technologist, that you've got continuing education credits aligned with your specialty. In other words, you don't have 40 hours of basket weaving as an IOM tech. And I'm being dramatic for a reason. I've had to look at we look at HR files as well. And I look at some of these and it's 20 hours of the same topic. How do you learn anything? But I also know that some people do their CEs just to get it done, not to really advance their knowledge base. So those are the kinds of things that are on the periphery of this scope. However, they have great importance and impact on you and your department. So this is where integrity comes in. This is where fidelity to the science comes in. This is where your professionalism comes in. And I think that was driven home a lot in the ASET presentation, because I had several people afterwards say to me, how do I do this? My supervisor doesn't support this. I'm going to have to do this on my own. And that is not a new phenomenon. That is, as many of us have had supervisors that they didn't know what we were doing. Likewise, I didn't know what they were doing. So I took it upon myself, and I think it's part of our professional responsibility to do that. So the end point of this is, remember, it's your profession. You make it or you break it.
Yep, very good. Nicely said, Kathryn. Well, thank you so much. I am very thankful to everyone that joined today and everyone that stayed on, spent your lunchtime with us. We are recording this, so we will make this, available after the recording. We did get approved through ASET for up to 2 CEUs, so that was up to 2 hours. So you will be getting that too. We'll make sure ASET, Kathryn and I both work with the educators there to make sure that they approve, that it's already been approved and that you receive those 2 CEUs. If you have any more topics that you would like to cover, please let us know. If you are working on getting your registry, I support you, and let us know if there's anything we can do to help you with that. As well as, Kathryn and I are here for you with any questions. If you think of something after the fact or while you're watching the recording, I see a lot of emails, so we'll definitely, send those out. Kathryn's going to share the CPT codes for 2026. Go ahead.
Don't expect a lot in EEG. It was
Okay.
IOM, but yeah.
IOM's more. Okay, awesome. And you said that won't be released though until the end of October, beginning of November.
Yeah, I have my copy, which
Okay.
I took the course in. I'll pull from there, but knowing that the final version is the end of the year.
Yeah. So I just want to make sure people aren't expecting us to send that out to them right away, that they understand that those finals then, as Kathryn said, will not be until after November 1st, at least, right?
Yep.
Okay. All right. Well, it has been wonderful, Kathryn, to do these
Good to see
3
you.
parts of
Thank you.
billing with you. I have
Thank you.
learned so much. I always learn from you. And I appreciate everybody on the call and calling in. And yeah, hopefully we'll be able to see Kathryn again sometime soon. And we'll be able to see all of you again sometime soon. So
And
thank you.
thank you to RhythmLink.
Yes,
Well,
thank you.
you need to understand what RhythmLink has provided you. It is
Yeah.
an amazing opportunity. So thank you all for supporting RhythmLink.
Yes, yes, absolutely. We really want to partner with the tech. That is our goal. We want to make sure that we're partnering with you and giving you what I want, what you need, and what you want, because I know what I wanted when I was a tech. So definitely we want to extend, out to everyone and provide that education, whatever way we can. So thank you so much for spending the afternoon with us, Kathryn. Thank you all. I hope you get a good lunch and or got to eat while you were with us. So
Thank you all.
thanks.
Thank you.
Bye.
Bye-bye.